Well, welcome everyone that's here today. Thanks for joining the fourth annual GSSA Symposium. We're really happy to now have converted this into a webinar, and we appreciate your support, joining us today. Obviously, a lot of changes have happened due to the COVID adjustment here at the University of Utah and all across the universities with the speakers that we had prepared. So with that, I'd like to introduce Dr. Sherry Wren. Professor Wren is the Vice Chair of Surgery and the Director of Global Surgery at Stanford. And she does a lot of work in gastrointestinal malignancy and robotics and research such as that. So, hey, Dr. Wren, how are you today?
Good morning.
So we'll let you get started and feel free to go ahead.
All right. Well, thank you all for the invitation, and I wish that I was there today. What I'd like to talk about is actually a subject that you don't hear a lot when we talk about global surgery, which is the humanitarian responses. I think many people know that the world is a complicated place right now. So, trying to figure out I don't know how to move my slides on this. All right, so this all started in the late 1850s. A Swiss man was in a Napoleonic War and looked at it and was horrified by what he saw. Therefore, he came back, and this was really the conception of how the International Committee of the Red Cross really got started. And the ICRC is what sort of governs humanitarian law and initially humanitarian responses. I think many people have heard of the Geneva Conventions, which are rules that govern states and armies in war, but I think a lot of people don't know that this is a huge area in humanitarian responses because of these ruling of how states and actors are supposed to respond. When you look at some of the most important Geneva Conventions, I think all of us can understand that you're not supposed to destroy civilian hospitals. Civilian hospitals are critical to populations. There are people always getting sick. I think we're going to see this in the COVID response. People are still going to have babies. People are still going to get appendicitis. So you have to protect these hospitals. You also have to protect the staff that works in this. And you also have to give care to people regardless of what side of the battle they are on. Well, if you look at what's happening now in this century, we're actually bombing hospitals. Syria has lost more than 400 hospitals in the conflict, and these have been absolutely targeted, specifically because if you take out hospitals, you take out the care of your local population. So I think a lot of people think that if you're a humanitarian healthcare worker, that it's sort of safe. And the old time you had a white Jeep and a white t-shirt, you weren't going to be having a problem. But there's many, many instances of healthcare workers being kidnapped, murdered on an ongoing regular basis. So how do we change this? And this is something through advocacy. I would hope maybe GSSA could get on board with advocating for protection of humanitarian workers. So this is sort of a world map of conflict right now. And just to sort of kind of talk about it, there's state-based conflict. What does that mean? That means that, the army of France declares war on Germany, and that's a state-based violence. So kind of formal actors. Non-state is when you have groups like ISIL. So they're not really state-based, they're militias or other groups, and one-sided violence tends to be things like terrorism. When you look at fatalities in the world, you can see from this line here, I hope you see my pointer, this used to be state-based, and then all of a sudden you see the rise of non-state violence now really being the largest amount of deaths around the world. And this is a graph showing fatalities in non-state conflicts. This blip right here, this was the genocide in Rwanda. So again, that was not a country at war, that was a country at war within itself. And you can see that this non-state violence is really increasing the amount of deaths that we're having. So how do we re-envision a response where we think about Vietnam or World War II, where it's two countries at war with a population in between, to now war is basically in your city and in your hometown? So this is a logistical problem. There's all sorts of things, but first of all, nobody actually really understands what the population needs are. If you think about it, we think about war and we think about people getting hit by guns and bombs, but we also realize that there's a lot of children, people have other diseases and pregnancy. So this epidemiology of what a civilian is undergoing in a conflict zone is very different than what the military. Our military members are protected by body armor and all sorts of other things. So the population has a different risk. So the military has really been leaders, the US military in particular, in how to look at injury epidemiology. They actually have incredible processes where they look at how everybody died. Was it survivable? Was it not? Every death is scrutinized. There's also been incredible, because they've looked at it, they've developed a trauma system, and they have embedded this continuous quality improvement through a joint trauma registry. And it brought us many advances, such as hemorrhage control, tourniquet use, resuscitation, and they have this 5-level of care. And you can see here that when they mandated this, it reduced these preventable deaths. So we've gotten very good at this. And there's an entire echelon of care that takes you within an hour to a forward team. Within 24 hours, you're evacuated. All the way back, you can get to the United States. This is non-existent in humanitarian responses. So currently right now, we have a lot of bad things happening to people. And because we don't know how they're going to get to a care facility, which is located kind of pretty far away because that's a safe zone, we have a lot of preventable deaths along the way. So what's this data source? How are we supposed to figure out what we're supposed to be doing? You would hope that in many ways the WHO, ICRC, or MSF would have data that we could look at. We have a lot of data on the civilian side, we have data on the military side, but I can tell you that this data is not actually there. So what we did very recently was to try and look at least published data to look at what's the epidemiology of injuries by civilians and local combatants. We started this in 2001. That was the start of Operation Enduring Freedom, which is the war in Afghanistan. You can see on the map the countries where this data is coming from. What did we find? If you look at it, not surprisingly, most of the patients are male, but compared to the US military data, 80% are male. Women are getting injured in this. Bombs do not discriminate. Also, the incredible amount of pediatric cases. This is a common problem. Children are getting injured at a high rate. What is sort of the mechanism? If you just look at this purple bar here, this is blast. Blast injury is much higher in the military. It's high in the civilian population, but then you get into other issues like assaults and penetrating injuries. Depending on what type of conflict, if it's rural, you can imagine that that's going to be a different type of injury pattern than if you're dropping bombs on a city. So unfortunately, this review was almost impossible to do because there was almost no data. Nobody reported things in a common language. Nobody looked at delays. 25% of the reports really just didn't have anything about injury. So we unfortunately had to conclude there was no great data, and we cannot at this time use this data to plan for a trauma system. So one of the things that we're working on now is how do you change this? So in conflict, we don't have this. We don't know how many women are pregnant and need births by cesarean. How do you begin to change this response? So about, I guess it's 2.5 to 3 years ago, I decided that we wanted to put together a group to look at designing this humanitarian surgical response for conflict. And we wanted to avert death and disability. And we had a number of things that we needed to do. It had to sort of adapt what we've learned from the military. We had to provide non-traumatic care, so emergency general surgery and OBs. We wanted to go from Reconstruction through rehabilitation. It has to function under international humanitarian law, and we wanted it to have a data and outcome registry. This is sort of what we're envisioning as the ideal response, that we could learn this military, we have these first responders now, we can get patients there in a timely fashion, they can get to earlier treatment, and we end up with survivors and less preventable deaths. So what's the response look like in conflict? This was a paper that came out of what MSF, what you would have to know if you wanted to work with Doctors Without Borders. And you can see the huge amount of OBGYN and orthopedics. Well, that makes a lot of sense. Those are standard injuries or standard diseases that happen to population. So civilians, you could have older people, younger people. It's just sort of a different type of way of thinking about this. You're well familiar with this essential surgical platform. And when you look at this, it covers OB, general surgery, and injury. So this is sort of a humanitarian response at its kind of distilling it down. So we wanted to minimize preventable deaths and assume sort of resources. I'm going to just kind of go through really quickly what we did. We had 35 international experts from humanitarian agencies, the military, civilian trauma, ethicists, academics. We basically did a lot of work and then had a 3-day conference to come to a consensus. What did we end up saying? We ended up saying that we should be training civilian first responders. The paper is now out. I'm going to refer you to it because I'm not going to go through everything that we said they should and shouldn't do, but we need lay first responders to be able to help in these situations. You saw that happen in Syria, and you see it happen in other areas. We need to have a rapid point where you can have the first sort of site of care. This is basically for hemorrhage control. This is the first place you need to stop preventable deaths. If you can stop hemorrhage, stop an airway emergency, and move people along, you could actually now save more lives. You actually see here, we talked about hemorrhage control and just chest injuries and chest drains. We're not talking about putting breathing tubes in people. This is sort of your trauma stabilization point. Now you need to go to definitive care. It has to treat injuries as well as emergency surgical and obstetrical conditions. This is a huge investment in both material and human resources. And how do you put this facility someplace? It has to be safe and you have security concerns. I'm going to skip about all of this. Rehabilitation, really, you have to think about rehabilitation is if you do an amputation, crutches is a form of rehabilitation. So making sure that patients can leave the hospital and being able to ambulate. Complex rehabilitation is going to be highly dependent and probably not being done in these settings because of hygiene concerns and resource concerns. So you can see here, we sort of had some minimum services, so skin grafts and local flaps, but not complex reconstructive services. What else do you have to put this system into place? You have to actually have pre-deployment education. You can't just take people and assume because they're doctors and nurses and healthcare workers that they know how to work in these situations. You have to actually talk about injury prevention. You have to have data collection and quality improvement. We then really are advocating for this right now, which is this minimum data set. If we cannot look at data from these humanitarian responses, we cannot improve our outcomes and know what we're supposed to be anticipating for to design responses. This is an example of what we put in the paper as sort of minimum data elements that we are going to need to have. At the current time, none of this has been done by any humanitarian actor. Other requirements that you typically don't think about. I don't know how many of your web viewers know anything about international humanitarian law. It's actually critical if you're going to work in a humanitarian setting. What are the local laws relevant to healthcare workers? How do you protect patients in these conflict zones? What do you have to know about what's called UXO and CBN, which is unexploded ordnance and chemical, biological, and nuclear. Security protocols, context. One of the biggest things is managing social media and actually not participating in many ways in social media. You have to be able to adapt this across very many contexts, both geographic, casualty numbers. You have to have multi-casualty or mass casualty plans. You have to have incident command structures. And how do you strengthen and coordinate with your local healthcare if it's present? You can imagine that these are actually two areas of conflict right now. There's conflict in Mali and there's conflict in Yemen. Yemen is an urban conflict. Mali is a desert, remote, very rural-based conflict with average times for evacuation now, in the best of cases, of upwards of 3 hours. So these are different responses, and how do you adjust your humanitarian response to this? This pre-deployment training that we talked about would kind of include all of these things. Again, I'm going to refer people to the paper in the interest of time. We have submitted this. We are now trying to work with the WHO to integrate this into what's called the Red Book, which is for humanitarian responses. How did we do this? This took an army, literally, of people. They came from everywhere. We had people from the WHO, MSF, Samaritan's Purse, which is also a humanitarian actor, ICRC, our military, American College of Surgeons, and a bunch of people from around the world. I could not have done this without all of these people, and I'm very grateful to them for the time that they spent in this. This is sort of what the final response looks like. I don't know if you are aware of what the Noun Project is, but it's amazing that there's a genocide collection, so you can find some of these things. But you can see that you have the trauma epidemiology and injury epidemiology of war here. You have landmines, bombs, guns, but you also have the needs of the population. You have pregnancy, GI conditions, car accidents, burns. Currently, we have no idea how long it's taking people to get there. My favorite patient once was delivered to me in Chad on the back of a donkey after an injury. 3 days. You're looking at a survivor because that person obviously was able to make it to me. Along the way, if you do not coordinate this, you're going to have people dying of their injuries. Now they finally sort of get to this definitive care, and you'll get to survivors. What's the system that we want to see built? We want to see community first responders. We want to see some coordinated transportation in a timely manner, getting into these trauma stabilization points. And again, movement of casualties to a definitive care facility so we can now get to more survivors. That's sort of the dream. I think with the WHO's Red Book coming out in the next year, I think we're going to see embedded in that some of these elements that are going to be required for humanitarian actors to respond in these settings. If people are interested, there was something that happened in Mosul, I think people know, and that's sort of been a very controversial trauma response. It was when the Iraqi military went in to liberate Mosul. The Americans were there as advisors, so they actually said that they did not have to provide the health care for the population that was getting liberated. The Iraqi government said, we can't provide the health care, we don't have the resources, and this was the first time that the WHO actually stepped in and actually contracted with a variety of providers and groups, some of whom had actually never worked in a conflict zone. And there are examples of great good and great bad that happened in that, because if you don't understand your context and the rules of humanitarian law, you sometimes do things that perhaps you shouldn't be doing. So I am going to stop this, and I'm going to stop my sharing. And I see that there are questions.
Yeah, let's take a look at a few of those. So one of the first questions we had here was specifically how medical students can get involved, or how they might be able to join something in a war-torn area like that.
Yeah, I would say probably I would not, I don't think medical students should be getting involved in this. I think unless you're willing to go and work in some aspect as a medic, so if you have medic training, resources are so tight in these areas, you want to be bringing people who actually are very trained and know what they're doing. So if you're a trained medic, I think there might be a role.
And what about for our future careers? How did you get involved in the beginning?
Yeah, I got involved by actually working with MSF, Doctors Without Borders. I would say that if you are interested in not just humanitarian responses, but actually working in low resource environments, when you're getting your training, make sure you try to do things like go and scrub on some OB cases. You want to scrub and participate in cesarean sections, treatment of postpartum hemorrhage. You really need to pay attention when you take your surge subs. So when Dr. Price and I trained, we actually rotated on things like orthopedics, and that's actually not done that much anymore. So when you're on your trauma rotations, make sure that you're looking at how are they putting in traction pins and all those things, because those are skills you're going to need in the future.
And to all of our attendees, we'll make sure to send you Dr. Wren's paper so you can kind of look through some of these things. We have a question here from Catherine. She asks, how can we mobilize local and international community actors, and how do you feel about improving primary interventions will support adequately enhancing secondary and tertiary lines and sites of care?
Well, ask that in two parts.
Okay.
What's the first part?
First of all, how can we mobilize to international community actors?
How do we mobilize? I'm not sure what that question is. I think humanitarian response is going to be done by agencies that really have experience in it. I think the three largest agencies right now is ICRC, MSF, and actually Samaritan's Purse. There are some other responders that are going out and working more in TSPs. I think if you're interested in doing this when you are fully trained, going and trying to work with these agencies would be the best thing. Most of these agencies will not have you work with them until you have at least 2 years of attending experience.
Great. And I think the second part of the question is, by improving primary interventions, how does that improve the secondary and tertiary lines of care for people in these areas?
So I'm going to interpret what that means is if primary intervention is that TSP point. So if you think about it, if you have an extremity hemorrhage, and if you're able to stop that with packing or a tourniquet, and then can transport somebody to where a definitive procedure could be done, you've now saved that person's life.
Thank you. One more question from Blake. She asks, basically, in the military, there seems to be a lot of resources for learning how to provide care. Is there a way for us as physicians or students to access any of those resources?
So I would say that the military will sometimes think they're going out low resource. Their idea of low resource is very different than I think other people's ideas of low resource. In the civilian setting, I think one of the ways is by preservation of hospitals and local providers. So if you're bombing hospitals and doctors, you are removing all of that capacity for those civilians. So Syria actually had a very well-developed healthcare infrastructure. They did transplantation in Syria. But by bombing and removing and targeting physicians, that's how the population really began to suffer.
Thank you. One last question before we have you go. To clarify just kind of the work that you did, do you specifically work with local communities and their humanitarian workers in the area, like for training and everything, or is it bringing in your own people to establish that care?
So let me just be clear, there's no I here. I am not doing this. So what we are advocating for those first level of responders is that this would be the local community. So training and educating the local community, including on injury prevention. So definitely investing in local communities.
All right, Dr. Wren, thank you so much. We appreciate your time. This has definitely been a powerful message for us.